I'll give it a shot. So our first presenters are Sarah Dekine Davies and Kenzie Jacobs from Children's Hospital of Colorado. And I'm going to turn it over to them to go ahead and get started. And I should mention, if you guys have questions as we're going through the presentations, we're going to reserve the last 15 minutes for questions. So go ahead and enter your questions into the chat window. And we will go through those for the last 10 or 15 minutes of the presentation.
Great. Hi, I'm Sarah Dekine Davies, and I'm the manager for Research Informatics and Advanced Analytics at Children's Hospital Colorado.
And I'm Kenzie Jacobs. I'm the Business Operations Manager within the Analytics Resource Center at Children's Hospital Colorado.
Today we're going to talk to you about data governance, and specifically we're going to talk about HR metrics, which even though our main focus is clinical at the hospital, we also do have people who are employed at the hospital, and so HR is a big component of that. And so we'll talk a little bit about how we've applied some of our data governance structure to HR terms specifically. So today we'll talk about what do we mean by data governance, who is involved in data governance at our hospital, how do you decide on standards for the organization, and how do you ensure that standards are being followed?
All right, so I'll take over to talk about data governance generally. For us, this journey began about 3 years ago when we started the Analytics Resource Center at our hospital. And we went down this path because we had a ton of data and reports and dashboards around the organization, but nobody knew what really existed, what definitions were being used for each, who had validated that information originally, and who owned it and could really answer questions about it going forward. To address that problem, we implemented a series of data governance groups, so clinical, HR, like Sarah mentioned, and department governance, to work on collating, defining, and standardizing common terms and metrics across the organization. Our goal was to ultimately ensure that data is consistent, trustworthy, and used appropriately. And we really just wanted to understand what existed and why. So as a part of the development of that data governance program, we determined that there were a few key steps that we went through every time we defined a term. So first, we figure out where to start. Our initial list of terms when we kicked off this process actually came from the metrics that our C-suite leadership could not discuss on their weekly huddle because nobody could agree on the definitions and therefore the numbers that were being reported. So it really started with a lot of leadership at the beginning. Once we work on a term, we do quite a bit of discovery and review before we actually get together for any meetings. We try and find the folks who care about the metric, those who report it, those who ask for it, those who develop the metrics around it. And we ask them a lot of questions. What's your source system? What are the components that matter? What are the workflows that impact it? What are the definitions that you use? What reports and dashboards exist to display those metrics? And then that discovery and review kind of blends into the research where we look at what we learned internally and then we look outward. What external registries define those terms? Where does the industry report on them, and how does the industry generally understand them? So that we can take everything we did in those second and third phases and attempt to get on the same page about the definition or definitions. This is the tricky, long part. It usually takes a number of meetings where we go through that research and review, and the group asks a ton of questions, most of which require a lot of follow-up. And the discussion usually lasts a couple of meetings where ultimately we decide on a term or set of terms so that we can publish them. We have a SharePoint that everyone in our organization can access so that once we have a definition, everyone else can use it. And we also either update logic or metadata, like names and descriptions, on the affected reports and dashboards that we found in that discovery and review phase. So this whole process, as you might guess, requires a multidisciplinary approach. Our executive leaders are involved. We often get assigned important terms that come up from in-flight organizational goals, which also really lends a lot of credence to the importance of these efforts when folks at the top are saying, can you help us fix this? So it's pretty important. The group that actually works together includes IT and analytics and folks from the operational side across the organization. And we pick our subject matter experts depending on the terms that we're talking about. So we might include case management if we're talking about admissions, or finance when we discuss patient days. And ultimately, the work that the data governance group completes is meant to be used by everyone. Ultimately, what we've discovered, and this won't be a surprise, is that data governance is incredibly contextual. We often finalize our work by listing many different definitions that may be related to one term and why each is important and to whom. So we might have, if we're talking about readmissions, readmissions numbers that finance uses for insurance. We might have an operational readmissions rate that's meant to improve care for our patients and look for process improvement opportunities. And we would also list the industry standards. If the CHA has a readmission definition, we'd also want to include that and why the definition differs from the others. It's really contextual. So that ultimately we're ensuring that our standards are followed. That's often one of the most difficult parts, and it's the final step in our process. We do the basics that I mentioned before. We publish our terms to the SharePoint site that everyone can access, and we update those affected deliverables that we found initially. But bigger picture, the best way that we have ensured that our standards are followed focuses on communication. We try and celebrate our governance wins. When we define a new definition, we have those. We send those out to folks who are affected so they get communication. We follow up when we hear folks talking about terms that we've defined in governance and asking if they use the published definitions. And ultimately, we try and be data governance evangelists day to day.
All right, so I'm going to provide a HR example, and that's the area that I oversee on the governance side. So, So first of all, I'll talk about turnover, which is a common term that is used within HR metrics. And so looking at this map right here that we showed, we've identified and prioritized the term, and turnover was the first one that we were focusing on. And then we went to the discovery and review phase. So for discovery and review, we involved a lot of different people in this process. This included HR records, who are actually updating the records in the system and verifying that they're correct. HR leaders who are involved with day-to-day discussions about a lot of these. The Analytics Resource Center, who would be implementing these definitions. The finance team, who uses these and does some of the reporting on this information. The Magnet team that actually reports this information out for both Magnet and Indy and QI. The ERP system admin and ERP developer who are involved with the design of the systems and really understand the underlying data models. When it came to the terms, we needed to understand the termination codes that go into identifying voluntary and involuntary turnover, since we needed to define both of those terms. We also had to look at other terms for how we would be stratifying our analyses. And so direct patient care, nursing staff, which was really important for the Magnet and Indy and QI needs, full-time versus part-time, as well as understanding the FTEs, who is PRN or flex, who might be benefits eligible, and then permanent versus temporary. All of these would play into the rates. Some of them might be excluded, while others might be stratifications. When we looked at definitions, we looked at both our pillar goals for the hospital, as well as voluntary and involuntary, what we were using for Magnet, CHA, Indy, and QI. And then we also discussed a term that we've recently called mobility, but has also been called churn in our organization, which involves turnover, but also has some additional aspects about internal movement in the organization. When we looked at systems, we looked at PeopleSoft, which is our ERP and our system of record, but we also looked at a lot of different additional data marts throughout the hospital, some which are manually updated and curated, that we're also reporting out some of these terms. Once we finished the discovery and review section, we went on to the research. So for research, we really focused a lot on the Indian QI definitions initially. So these were total turnover rate, voluntary turnover separations, as well as the magnet terms, which are part of Indian QI for reporting out at least. And then the magnet definitions, we had controllable turnover and uncontrollable turnover, which was a little bit different than our voluntary and involuntary that we were looking at. And then we also looked at the SHRM definitions, which aligned with several other HR resources as well. And so that was just the turnover definition is how they term it. And so we did a lot of research to understand what the different aspects that went into each of these and when they would be used, both when we were using them internally and then also how we were reporting them out. After we finished with our research, we went to define the terms, and this was the most exciting part. So this is just an example of how we define our terms. So we identify the metric and provide the status of it currently. And then we indicate what the population is, the numerator, denominator, any additional logic that might go into the population numerator or denominator. Any exclusions, the time periods that we're using for reporting out, and how often we're updating this. And so we are very standard in our HR metrics that we always update them at the same time each month. We do have a little bit of a lag because of the fact that terminations might be entered a little bit late in some cases. And so we want to make sure we get all of those updates. We also, you'll see here, we excluded students and interns, and the main reason for that is because those are not expected to stay for an extended period of time. They have a limited term, and so they were excluded. You also notice that our pillar turnover is different than our other turnovers, and that's because we have a very specific population when we're looking at it from a organizational pillar aspect. Here's an example of our data mart definitions, and so this is a bit more technical, and it looks at both what our column names are, as well as the description, the format for the database, which values are acceptable, the additional details, so any information that we need to understand about it, so either how it's being calculated or information about when we might have exclusions, et cetera. And then one of the important pieces with HR data especially is security considerations. And similar to PHI as well, you'll have additional security considerations for certain fields. And so for our organization, age group, pay rates, sex, race, other demographic information are a little bit more sensitive than others. And so we don't want that information to be discoverable. So it's very limited access on those. And then after we defined our terms, we moved to publishing these terms. And so when we publish, as mentioned before, we're publishing them on the SharePoint. We're also updating our data marts that are feeding reports and dashboards. In this case, we actually created a brand new self-service dashboard so that we'd have consistent information across all uses. And then we retired our old reports and dashboards to the extent that we could. There are still a few that are out there that we are working on retiring to make sure that we can fulfill all the needs. Here's an example of what our turnover looks like. And surprise, surprise, that people have not been leaving as often in the last couple of months. We have seen a big change with that, where it's much different from prior years. And we do have this very self-service so that we can look at lots of different areas in the hospital, as well as limit the population filters as well. So some key takeaways that we have is that really data governance requires a multidisciplinary approach. You can't just have one person making the decisions and trying to get the rest of the hospital to comply. You really have to make a partnership so that everybody is on board with the definitions that you come up with, and then also willing to move to those definitions. Discovery is really key to understanding the various uses in the organization, as well as how it's being reported to other entities. Standardization is required, but as we mentioned before and Kinsey said, you sometimes have to qualify it. So our organizational pillar goal is different than what we're reporting for Magnet, and that's okay as long as we're qualifying it with that description of what it is. Standardization needs to start from the source systems, and the changes need to be monitored for impact. And so a couple examples of that are our client services managers review all turnover in our system to ensure that they're adequately marked as voluntary versus involuntary to make sure that that's clear. We also have our records team that manages to review all entries to ensure that they're complete and that have all the information that they need. Also, every time a change is made, so if a new termination code is created, then that is put into a table that is accessed both for the live ERP system as well as for our data mart, so that we should always have the same definitions across them.
Sarah, sorry to interject for a second. I think, are your slides stuck or are you able to advance? We're still seeing the data mart definitions and specifications.
Oh.
Are we on the right?
Okay, it's showing key takeaways on mine.
Oh, interesting. Okay. Do you want to try to go back maybe and see if we can, if not, we can maybe turn it over to Kenzie, or I can maybe get the slides up if they're not advancing.
Should I retry?
Yeah, if you don't mind.
Okay. Can you see now?
Yes, now we're perfect. Keep
all right, sorry about that.
Awesome. Thank you.
All right. And then, sorry where I was. Oh, so also as Kinsey mentioned, we need to make sure that we inventory the uses to ensure that only standard sources and definitions are being used once published. And so that's important so that you have consistency across the hospital, and you don't want somebody saying, oh, well, I thought our rate was 5, and somebody else saying, oh, I saw that it was 20, because then you have mistrust in the data. So you want to make sure that you've rounded up all of the different uses of it. And that's all I have. All right.
Okay, can people hear me to say great? Thank you so much. I also love the idea of data governance evangelizing, so that's what we're here for. I think next, Michaeline Green from our institution, and she's going to talk about hazard assessment and data governance decision-making.
Hello, can you hear me? All right, I saw some nodding heads, so that's a good thing. Hello, everyone. I am Michaeline Green from Lurie Children's Hospital of Chicago and part of the data analytics and reporting team. And I'm here to talk today about hazard assessment as a methodology that we used and tying it to informing our data governance decisions for a specific project. And I love following the example that you just gave with all that kind of rich human resources data, which I know is also often considered very sensitive. Our care to not misuse that type of data is so important, as it is with all of our data, but I think it's a great example where we think about why data governance is so important. Let me advance here, sorry. So my objective is to go over in the next few minutes. We're really trying to highlight the tension between the benefits of increased transparency, but understanding that tension between risk and benefit. I'm going to use an example of a hazard assessment approach, and we specifically used a bow tie analysis. So I'm going to walk through what that is and how we used it, and show how this has helped us strengthen our collaboration our collaboration for risk mitigation and helping us get to the point of increasing access and transparency of data. So with that, I want to give a little bit of a background. The thing that we call the Knowledge Center is an online resource, online tool to be able to dramatically increase transparency of data in our organization. We are building it now and approaching our go live of this resource. And to get to that point that we have, I think you just gave an example of you want everyone to know the same number when you're looking at a key indicator and not have different rules and different interpretation of what we think that is. So this widespread transparency is going to help us get there. We're building upon work that's already been done over the last several years of having really increased our capacity and our sophistication with data analytics. And we've seen with that, we use Power BI. There's some other tools that we use as well, but Power BI is the main tool for visualization, has helped us dramatically increase utilization with online access to data, analytics and visualizations. We're trying to get to that next level where we really have more widespread transparency, especially around key indicators, to be able to achieve a shared situational awareness or a shared mindset understanding throughout the organization, so especially high-level metrics, key indicators. We're also taking advantage of the fact that we have data governance structures and processes in place that help us assess risk and benefit relationships as we continue to increase our utilization transparency in the way we manage our data. So we say the challenge with this project is not just to increase the visibility of data, but to also improve our data integrity and appropriate utilization of data. And in this work of hazardous assessment, we really focused on that appropriate utilization of data as being one of that risk-benefit tensions that we want to understand. So this is an example of what the Knowledge Center looks like. It is a SharePoint online site. I'm not going to get in this presentation and navigate to all the different data visualizations, but really what this is a one-stop shop to go in where a user within the organization can go here and access a number of different visualizations of data on a number of different topics by navigating through SharePoint Online, clicking on these buttons that would take them to an embedded Power BI image with the data that they want to see. Underlying this SharePoint Online site, the technology that we're using is connecting data sources. They might have multiple sources of data that the data are visualized through Power BI, and then the Power BI visual is embedded in SharePoint Online. So again, just as some background. So we're using two frameworks for our decision making in this project, and one is using for to define our use case. Summative lens on our use case is shared situational awareness, but more specifically, we want to be able to be effective in using data to support our ability to monitor, our ability to respond, our ability to anticipate, and our ability to learn. And that, of course, also gives us something that allows us to get into a different level of inquiry, taking advantage of all that robust development of data in Power BI that allows people to interact with data in different ways. The governance framework that we're using for this project has another level of detail, but it really comes down to 4 big buckets: decisions regarding access, utilization, technology, and technology integration, and then the integrity in the underlying data, the integrity of how statistics are applied, and how the data are interpreted. For the purpose of the hazard assessment, it really brings our focus to 2 of these buckets. One is the access, who has access, who gets to see what, and the technology and any potential risk associated with the technology that we're using. So I'm going to get into in a minute, I'm going to get into talking about what a bow tie analysis and how we used it, but first I want to stop on sort of this tension between the risk and benefit of increased transparency. So I think many of us that have been around a long time have lived through cultures of hesitancy around transparency with the thought of really focused on the risk. And one way to avoid risk is just to not be transparent. But I think over time that we continue to learn and understand that limiting transparency also has negative consequences. The lack of transparency, while it could be considered risk avoidance, often the lack of transparency erodes trust, engagement, and learning, and the things that are critical to getting better outcomes. And it also creates blind spots, poor situational awareness that makes it difficult or impossible to really get to those best possible outcomes. So we agree that we need increased transparency organization. We don't want to just avoid the risk. We want to understand it and manage that hazard. So for that reason, we took a hazard assessment approach to try to get a better handle on that. The approach that we use is called the bow tie analysis. Probably not a common terminology that we use all the time, but some of what's in it is very familiar. It's considered a combination of a fault tree and an event tree. And a fault tree is a similar type of thinking. We use the term root cause analysis more often. There's a bad thing that has happened or a bad thing that we're concerned about, and we investigate the linear chains of cause-effect relationships to try to figure out how to prevent that bad thing from happening. An event tree is similar. You look at a risky situation or a bad event, and you map out what are the potential consequences or the potential harms of that event. What a bow tie analysis does is it brings these 2 sides together. And what I hope to show in the next couple slides is it really helps you think differently, not just down the pathway of cause, effect, and prevention, but helps you think both about prevention of things that can be prevented and containment of things that may have been unanticipated, but can still be managed to not cause big problems. So let me give let me give our specific example. This is actually the template that we used, and in our bow tie analysis session, it was a little bit of pre-work, but most of the work was done in a 90-minute session in collaboration with our compliance team. And that includes our privacy office, it includes enterprise risk management, and a few other of our compliance-related functions. And we started out with, you'll see the map, it kind of looks like a bow tie. Starting out in the middle, and you acknowledge that the hazard, that we are going to make this step to be being more transparent with our data. So we acknowledge that there's a potential hazard by giving more people access to drill information. And we started out with a description of the hazard as it was different because it was outside of EPIC. That evolved a little bit in our session. I'll explain that more in a minute. And then we also thought, again, I mentioned the difference between a root cause analysis. A root cause analysis, you start with a bad thing that happened and work backward. What's different in a bow tie analysis is you're trying to take a slightly broader lens, and you're thinking, what's a critical tipping point that on one side I can be thinking about prevention, on the other side we can thinking about the realism that we might not prevent all problems, but some of them can be detected and contained while the problem is not a really bad problem. So to explain this a little bit better, I'm going to give an example that's close to my heart, because more than most people, I really like winter. And in particular, I really like cooking out on the grill in the winter. It's actually one of my favorite things to do, and to see reactions of people walking by when they smell that hamburger on the grill in January in Chicago. But so here in the example, the hazard is something that we acknowledge. This is a hazard that I'm willing to accept, but I want to effectively manage, cooking on the grill in the winter. The tipping point in the middle is not the really bad outcome. It's the point where something is starting to get out of control. And that's where the thinking is a little bit different than other analysis methods of trying to figure out what is that key tipping point where all my plans for prevention might not be sufficient. They might be good to prevent parts of the problems, but there might be a situation that's getting out of control, and I want to manage it before it gets bad. You'll see here some of the risks that I identified are not just general risks associated with grilling, but in this case, they're associated with the specific condition of it being winter time. And you'll see some of the detection methods and the prevention methods are also considering this specific hazard. What's different? What are we doing differently? The detection and containment side is similar. There might be situations that could happen in summertime grilling as well, but it's recognizing that despite the effort to contain all risk, you're still in somewhat of a hazardous condition, but it's one that can be managed. Let me go more to our specific example, and what you see here is the outcome of our hazard analysis session. This is our summary document from our actual session. So you see we refined the hazard. We actually broadened it a little bit in just that the electronic access to the quality and safety data was the specific hazard that while we think that increased transparency is a very important thing and a good thing, we want to manage the hazard. And we decided that the tipping point, our description of the tipping point would be the inappropriate use of data, intentional or non-intentional. That's a tipping point, the thing that we're trying to prevent, but recognize there might be some things that get through that we want to detect and contain before it becomes a bigger problem. So as a group, we discussed these two key items in the middle. We then went over to the right-hand side of the page where you see likely harms. What you see there are just 5 big buckets, but in reality, during our session, the group brainstormed, probably had about 30 or 40 different post-its of what are the things that we're really concerned could happen if there's some inappropriate use of data. What's the kind of the worst case scenario of what could happen related to that? And that brainstorm ultimately got summarized into these groupings so we could organize our thinking. We then went all the way over to the left-hand side and talked about what are the underlying risks, the latent risk. There might be some that are generally true, but some that are specific to this new thing that we're doing. And then from there, naturally, when we were brainstorming, again, on the latent risk, we probably had 30 or 40 different post-its that we were able to organize into categories. And then we could get more specific in trying to line up what are some of the things that we already do for detection and prevention to prevent an inappropriate use from ever happening. But then one of the things this method also does is it sort of forces you to acknowledge you might not be able to anticipate and prevent everything. So we also need to think about things, how do we detect a small problem that gets through? That tipping point gets to the other side of the tipping point. How do we detect it and how do we contain it? It's not uncommon in this methodology where you have more thinking and more developed thinking on the detection and prevention side, and far less development in our thinking on how do we detect something past the tipping point and how do we develop a response method that really helps us contain the problem while it's still small. And that's where this analysis kind of helped us think of things that weren't on the list of things to do before. I'll point out one other thing that the bow tie method challenges you to do is thinking about escalation and thinking how do problems get bad to worse, either on the prevention side or on the escalation side. And it really comes down to this box that we have here of when all of our thinking and preparation is on absolute prevention, we might not be doing enough monitoring or thinking through our response capability where we could still manage problems when they're small. So this is a summary of our findings, and again, a highly summarized view. We have a much more detailed version, but we came up with what do we want to do for better detection? What do we want to do for better prevention? And what do we want to do for better containment? In the detection, we came up with new specific things, thoughts for how we may go about monitoring. On prevention, there was a lot that was in place in terms of rules, standards, policies, and some methods of prevention, but there was an opportunity to strengthen those and make them more specific as we develop and go live with the Knowledge Center. And really one of the key prevention strategies was how do we use the Knowledge Center and that visibility and transparency to help us with this shared situational awareness for managing this problem as well as others in the organization. And then on containment, I loved in the prior presentation the term churn. I had never heard before, people moving throughout the organization. One of the things that we recognize that we don't monitor as closely as we could is people that move from one role to another, but they still have access to everything they used to have access to in a prior role. So that was identified as something on that other side that we had not been thinking about quite as much. So I'll just wrap up by saying that this method helped us think through this in a different way. And we really found that this was a way for us to come together with a shared goal of how we're going to mitigate risk, not complete risk avoidance, do the thing that we need to do, but how we work together to mitigate risk, and that a really comprehensive approach needs collaboration. Probably the biggest takeaway was there's an increase in monitoring, different kind of monitoring that we can do to contain risk. And we need to think through what the response protocols look like on that side of things. And probably the most valuable thing was recognizing that the thing that we were doing in building the Knowledge Center was not only a potential hazard, but a potential solution for our enterprise risk management strategy. And I will stop there.
Great, thank you so much. I think my take home was that I need to better assess my reputational harm risk for my grilling activities, because clearly there's more there than I thought there was. But on the serious side, I think that that's really a good formulation that helps people think about risk as a non-binary and understand harm reduction and how to balance costs and benefits. Next on our agenda is Ashley Clark, who is Data Governance Specialist in Data Analytics and Reporting.
Thanks, Michael. So I will be presenting on our implementation of patient-reported outcomes and assessments, or PROAS for short, into the electronic medical record and some of the complexities we faced and experienced along the way. We found that there are many aspects of building and implementing questionnaires into EPIC, which is Lurie's EMR, that were not apparent until we delved into the builds and workflows of our pilot projects. One of the largest hurdles we faced was finalizing our request intake process and learning all the steps and information necessary for the builds. We discovered that the information needed for builds includes very specific assignment rules, triggers for questionnaires, like visit type for automatic assignment, clinical thresholds, and training needs. So Lurie Children's has been in the process of building patient and family surveys into the medical record so that the process of scoring and tracking patients over time is more efficient and effective. PROAS have been defined as any report of the status of a patient's health condition that comes directly from the patient without interpretation of the patient's response by a clinician or anyone else. And in the case for pediatrics, it's typically a parent proxy who will answer the questionnaires for a child. The patient-reported outcomes are important because they provide a patient perspective on a disease or treatment that may have not been captured by a clinical measurement, but may be as important to the patient and their adherence to a treatment as a clinical measurement. Our goal is to build patient and family surveys in EPIC so that taking them, scoring them, and tracking the scores can happen in real time. And the surveys can be taken in our patient portal, which is MyChart, either before or after an encounter, during the welcome and check-in process, either through a tablet or through an activation of MyChart in the waiting room, or with the provider during an encounter if needed, for example, if there's a language barrier. So this is just a brief workflow of what happens when a patient answers a questionnaire. So a schedule is an appointment is scheduled, and normally there's a push out for a questionnaire when a appointment is scheduled, and the patient can go into MyChart, click on their appointment, and answer and submit the measures. And then on the physician and clinical side, they can open that encounter and they can see the questions and the responses. And if then there is additional reporting needs, then our data and analytics team can step in and provide those as well. So this was our original workflow from the pilot before we actually delve into building them. And I really just wanted to show, especially in the intake phase, how much more complex it became after the pilots. So this is our current workflow for PROA requests. And if you noticed in this intake and approval phase, there's a little bit more of a hierarchy of approval and complexity to it. So a requester will submit their request in our data request system, and then the request will go through our intake phase. And this can range from the request entering into our request tracker to our PROA coordinator, which is myself, facilitating meetings with the requesters and coordinating the licensing and permissions with the publishers if that's applicable. Also during this phase is the validation of if it can be built into EPIC, is it clinically appropriate, is it scientifically acceptable? And typically it starts in our PROA core team. We have that discussion. If we feel that it needs to be further discussed, we will escalate it to our PROA standing committee. If they feel it needs more discussion, it can be brought up again to our health and information management committee. And then very rarely, it could be escalated to our quality informatics team or physicians advisory committee. And then once it is all approved, all the licensing's done, it can finally go into the build where our information management team and an analyst will design and build the questionnaire into Epic. It'll go through tests and workflows. There's training, then it can go live. And then after that, we have a database, a PROA database, which I will show later on, that shows all the measures that are in production and the metrics on those. So I first just want to go through kind of what was in scope for our pilot program. We first wanted to complete the test builds for our 4 survey pathways, and a pathway was determined by the complexity of the build and the scoring. We also wanted to estimate costs for future builds. We wanted to sketch the process of onboarding a survey or the intake process, clarify the workflow for research projects and how that may differ from clinical only projects, and also develop guideline documents and databases for clinicians and researchers who may want to use surveys. I highlighted 2 of them because they're the ones I'm going to kind of touch on in this presentation, but we had quite a wide scope with the pilot process. So these were our 4 original pilots, pilot pathways. So the first pathway is something that could have been easily scored within Epic, and it goes up to the 4th pathway, which would be something that is scored in an external application like an API and then pushed back into Lurie. And then these were our pilot measures that we started with. So pathway 1 was like a PROMIS measure, something that can be easily scored with Epic, down to our 4th pathway, which did have an external application to which it would be needed to be scored into outside of Epic and then pushed back into Epic. We found when we did these measures in the intake phase, we really needed to come up with a way to get all the information we need to not only build the measures, but to also prioritize the measures to make sure we're doing proper governance of the measures. And so we came up with what we call a playbook. And this is a screenshot of it. We do it in Excel. And when requesters request a build, we send this to them in the very beginning. So the first tab is to gain an understanding of the department structure and the work or project plans that the survey and assessments will support. So first we'll ask for contact information for people with departmental decision-making authority. This is to make sure everybody is involved and everyone's on board. We've had a situation where someone wasn't aware that PROAs were being built for their department until the end. So we now ask for everybody's information and we make those contacts just in case. And then we also on this page will ask survey assessment tool questions. And this is questions around if the tools are supporting a project that will enhance the organization. So if it's supporting our annual work plan, if it helps Lurie's meet compliance or regulatory standards or nationally recognized care standards, US News and World Reporting, and this will help us to determine the prioritization of a tool or assessment. Typically we prioritize by request date, but if something comes up in this section that flags it for higher prioritization, that's where we can determine that. Also research projects have a higher prioritization. The next tabs would be for the tools, and we do individual tabs for each tool they request. This helps us to gain an understanding of each survey assessment tool description and usage. This is where we can get the copyright and permissions info. We ask more questions to determine if it's clinically appropriate. We ask questions to see if it's scientifically acceptable, if it can be built into Epic. We also start to ask in this section some entry build workflow questions, ones that the users may not necessarily know right off the bat, but something we want them to start thinking about to help improve the process for building. So the expectations for how they want the patient to answer the measures, the frequency, and that they're going to push it out. Is it going to be a questionnaire series? Are there clinical thresholds? Visit types for automatic assignment, things like that. Next we'll do its custom reporting. So within Epic, they can see the questions and the answers that the patient submitted. But if they require more advanced reporting, then they can fill this out, and it could be done through our data and analytics reporting team. This is especially usually more relevant with research projects than clinical ones. And then the last tab is just more pertinent for research projects. Research projects can add a level of complexity to not only the builds, but also the governance. And this is just to gain more information about a research project, about where the data is going to come from, where it's going to go, what it's going to be used for, etc. So that's only filled out by our research project teams. And then the next next thing I wanted to talk about was just how we support clinicians wanting to use PROAs. So what we did was we developed what we call an item bank in Power BI, and it's available to all clinicians. It's actually available to the entire hospital, so that they can search scale or requests, scales, questions, and items within those questions. And I can bring that up. Second. So this is in Power BI, and the first tab is just our request list. So these are all the measures that have been requested and their status, whether it's just been requested, if it's in the intake or the build phase, or if it's in production, if it's already been built and being used. They can also see what department had requested it as well. And then on this tab, we can look at the items that are actually in production. So we can, this can be used for clinicians or researchers looking to use measures to see the metrics. It can also be used for the data governance to make sure we're validating the metrics when a measure is pushed out. This tool will really encourage repeated use of high yield measures. And then it'll also reduce unnecessary repetition or overlap when it comes to the request of the measures. And then in conclusion, the implementation of patient-reported outcomes and assessments is not a black and white process, as we found out in our pilot program. There is a lot of gray that can affect timelines, prioritization, and clinical and research workflows. The data governance of PROAs requires a lot of oversight, standards, and prioritization to protect the integrity of the process for implementation and maintenance. Communication, documentation, and collaboration between departments is key, not only between your requesting department, but there's also a lot of interdepartmental work within the PROA core team itself. And also just being open to feedback, not only feedback from requesters, but also giving feedback back to requesters. And that will really help, as we've found, to help smooth out the process for requesters and also help us smooth out the process for ourselves. And that's it.
Great, thank you so much.
Thank you. We have one question so far. It's a two-parter. So for both the HR and the EPIC projects, what was the first part is the time from beginning to release. And then the second part of the question is, if you need to add a new item, a new survey in EPIC, for example, how long does it take you, and do you expect that time frame to be reduced with experience?
So we can answer the HR one first. So governance takes way longer than anybody wants. I'll put it that way. Each time we start with our first terms within each of the areas of governance. So we had a clinical track that we did initially, and we had the HR one that we did. The first ones always take the longest, I think, just because we're still getting the actual details together. Kinsey, for the turnover specifically, that was a couple of months, right? So that one,
Yeah, it was
yeah.
a couple months.
Yeah, so now the one thing I would say is that it laid a lot of foundational work though, because some of that time was spent identifying the right people to talk to in the organization. And then also, one of the things that we found is that it wasn't just turnover that we were defining. We needed to define all the terms that were related to turnover and that we wanted to stratify turnover by. And so that has actually been an ongoing process. So beyond just defining turnover, now we're making sure that all of the data elements that people want to use with turnover, and so to cover a lot of the use cases that were identified, that those have also been defined. And so some of those take a long time and some of them don't take as long. One of the ones that has come out as a standout item to try to define is what is our organizational hierarchy and how should we be reporting out. And that is still a huge debate because our finance and our operations do not agree at all in how that's done. And so finance says that our nursing division is 10 divisions, but nursing says it's 1. And so there's a huge disconnect there. So we actually have a larger data governance process that's going on within the hospital among the senior leaders to talk through what does our organizational hierarchy look like and how do we apply that to all of the metrics that we're reporting throughout the organization.
Great, thank you. Would anyone like to address the for the EPIC projects?
Sorry, I'm just rereading the question. Let's see.
So the time from beginning to release.
It depends. It depends on the amount of measures they're requesting. It depends on if it's a new measure, if it's a measure we have existing. A lot of it also depends on external factors. A lot of times the permissions and licensing process can take a while. Once it gets to the build process, it's only, as long as they're able to get their workflow meetings, it's only a few weeks after that. But the intake process can take several weeks to a couple months, just depending on how complex the measures are and the different licensing we'd have to go through.
And then how long does it typically take if you want to add something, a new item?
Again, it unfortunately depends. Once we can get the intake phase done, once we can get the permissions and the licensing, the actual approval of a measure doesn't take that long. And we don't typically have to escalate it into a lot of those groups. But I would say the biggest lag happens with the permissions process. Sometimes someone can get back to me in a day or two. Sometimes it takes me reaching out 3 or 4 times before I can actually get a response. So, and some measures are scored really easily and some require a lot of more complex scoring methods. So some can take just a couple weeks from the build process, and then some can take, we have one that's taking months just because the scoring is so complex. So.
Thank you. Do we have any other questions? And since we have a smaller group, if you feel comfortable either way, putting it in the chat or unmuting yourself and sharing either way. Great. Well, okay. Well, thank you all very much for these are amazing presentations, and we really appreciate you taking the time out of your schedules to join us. I should mention, we have been posting these videos on a YouTube channel, and you should be getting announcements for those. So, so look out for that. We should have this one available probably, I would say, Ashley, what do you think? Next week, maybe? Yeah, probably next week. And then I believe our next session is October 2nd or 3rd. I have to look at the calendar, but we'll send out an announcement for that too. Michael, any final words?
No, great presentations. Thank everybody for coming. And I'm sorry about the initial technical problems, but great work.
It's to be expected, right?
Absolutely.
All right. Thank you, guys. Have a nice weekend, all.
Bye.
Thanks.